Thanks, everybody. We have a little bit of time. I'd love to open up to questions from all of you guys. Anybody want to start off? Do you want me to start off? Do you want to shout and then see if that microphone works?
Yep.
Super.
Do you want me to just use one of those or stop?
Yeah, here, Al.
Hi, my name is Tyler Scaff from Mercy Health St. Vincent in Toledo, Ohio. Just asking, we don't really, as far as I know, we don't really have a disaster medicine or Doctors Without Borders, or really any type of way to get involved with these sort of trips. I just wanted to ask for your all's advice. For somebody who's interested in doing these types of trips, how did you all get involved? How do you get started?
So I would say this is probably the most common question that I get asked. I don't think this is working, so I'm sorry.
Here, see if this one's better.
Okay, I got a big girl voice. You guys can only hear me, right? Yeah. Okay. Well, I'll just use my big girl voice. Okay. So this is the most common question that I get asked. I would say that there's a variety of perspectives on how this should be approached. One of the things that I would say, I want to plug a resource that I didn't get a chance to plug in my talk, which is Sugar Prep. The sugar, like what you go put in tea, prep.org, is a great way if any of you would like to educate yourself on some of the interventions that we've talked about today. This is a plug-and-play simulation curriculum designed for residents. So if you want to make yourself more ready for an experience overseas, I strongly suggest looking at that. Secondly, if you're looking for an experience overseas, I would say getting involved with things, international organizations like IFEM, like the organizations associated with SAEM that helped organize this didactic. That is probably the best way to be made aware of activities outside of your home institution that will allow you to get to places where you can make a difference.
I'll toss in. Sorry, David, you want to go ahead? No, I would just say that, I think many of us have been lucky to have mentors who we got started traveling with. I'd really encourage you guys, don't just buy a ticket and show up somewhere and be like, hey, I'm here to help. Go with a mentor who's been doing this, who has been very thoughtful about what sorts of engagement are helpful and what is creating an additional burden to the centers that you're going with, and go where there's already a track record of collaboration and engagement, where you're going to be well prepared to actually make a positive impact.
Before I went down to Haiti, so one of my fellows, she came from Akron Children's, and they had to do routine cardiac trips down there. And when she came to New York, I was lucky enough to kind of go down with her. So she was my liaison, and they have a wonderful kind of program, kind of bringing in. But what I realized at my home institution, there were at least 24 different entities that were going down to Haiti. And that's unfortunately the problem, is that the communication amongst it. So it depends on your discipline. I guarantee you there's someone in your hospital that is doing something. They may not be on a grand scale, but they may go with a company or a program. But I just want to parlay what Adam was saying. Don't go where something's already established, especially if that's your first time. You don't want to be that first person there yet. If you have seasoned experience and stuff like that, it's different. But I want you to love this and grab onto it and keep going. So that first experience, I want that to be a positive.
Anyway,
May I add to that?
please.
John Millay from Toronto, and I'm just going to put in a bigger plug for IFEM, the International Federation of Emergency Medicine, where I am the chair of the Clinical Practice Committee and therefore work with Adam. There are a lot of different ways of being involved and being supportive and being helpful than just taking your own body from here to there and working for a week or a month or a year. So being involved in education and in advocacy and in training and in solidarity are also all important as well. So the
I will toss out, as we're self-promoting, the SAEM, the International Conference on Emergency Medicine, is next month in Melbourne. For those of you who aren't able to make it to Melbourne, it's a hybrid conference. So one of the blessings and curses that's come out of COVID is the hybrid conference model, but this is a great way to get engaged with a international community of emergency physicians without leaving the comfort of your own home. Yeah.
I have to promote something too then.
Do you want a microphone?
I can also use my face real quick.
All right. You want to stand up?
So something that I'm going to get my residents involved in is Physicians for Human Rights has been doing work to write medical affidavits for refugees seeking safety. And they do trainings on how to do these exams. And then we have a great med2 group that gets together and actually writes the affidavit and partners with the lawyer group. So that's a great way to do global health type stuff and make an impact without drowning people.
Other questions? Well, while you guys are thinking, I'll shoot off one. Because in addition to being excellent clinicians and excellent human beings, you guys are also all excellent teachers. And I would love to hear a little bit from you about when you're teaching in a low resource setting, how are you adapting your teaching practice? How are you approaching residents or trainees in Rwanda, in Lebanon, in Haiti, to make sure that you're making a positive impact on them and adapting how do you work with them differently than how you work with American trainees in your home institution?
So I think from my personal perspective, it was hard to kind of adapt different strategies, but also it was a little bit easy because I'm from Lebanon, and so I went to medical school there, so I was very familiar, obviously, the language, I grew up there, familiar with the territory, but training here and spending a lot of time before moving back, I kind of had to shift, back to, well, what do you guys know? And you have to figure out kind of what the residents over there know initially, and kind of what their level of expertise and what they're missing, and then try to fill in a lot of the gaps. And so sometimes language is a big issue, right? So, I mean, I've had residents who come from Egypt or from, Syria that, barely speak any English, training in Lebanon, and so you have to kind of, incorporate some Arabic as well. So language is a big issue. The equipments that you might take for granted, over here, like, oh, let me teach them about ultrasound. Well, I mean, the ultrasound machine has been kind of non-functional for like 10 months. All right, well, let me give you a lecture about ultrasound, and then once we get the machine, we'll kind of do like some more hands-on. So I think you have to figure out what the gaps in your resources are initially, and then figure out how to incorporate that into the education of the residents over there, which for me initially was not easy because I was kind of a little bit, coming from training here, we had everything, and then I went back, I'm like, all right, well, you guys don't have anything, so now we have to kind of fill in those gaps.
So one thing that I think is really important when thinking about developing a teaching strategy in a place that you are not from is to come at it from an all teach, all learn perspective. Whenever I have taught something, I have learned something also. I've learned something from the team that I'm at least nominally supposed to be teaching to. And understanding that everybody who's in that room to learn with you has wisdom that they're bringing to the table, that you have to make sure that they feel safe to use their voice, safe to tell the stories that they know, and that you are a facilitator of the learning that's happening between peers, between cadres, between you as the instructor and the trainees who you have real responsibility for. And that I think in the US, I have a lot of people helping me identify, like, what does this particular learner need? When I'm not in the US, I often am the only person who is focused on what does this particular learner need, but it doesn't mean that there's any less need for individualized learning for trainees in other places or learners in other places. And so making sure that you feel comfortable as an educator building those kinds of individualized plans without a lot of the backstopping that we have in higher resource settings is a thing that I would encourage you to develop as a skill if you want to be an educator in all the places.
Just to add a little bit, because those were fantastic points, and I think I want to just echo. It's the language piece that I think it's really important, especially if English is not even on the table. Always have a translator or someone who really understands what you're trying to say, because being an educator, your biggest challenge is who are your learners and
Yeah.
Thank you for the talks. You guys mentioned this with some in the talk, but I was curious about your employment model. It seems like you spend a significant amount of time in Rwanda. So like, how did you navigate that? Like, is that something that you fell into later in your career? Because I've heard of, kind of how some positions have protected research time, some have now created protected global medicine time. Is that something similar for you?
So I think that is a great question. Thank you for asking it. I think we don't talk about money enough in global health. All right. Many times, when I am mentoring somebody who says, "This is what I want to do. This is my passion," I tell them it is the most expensive hobby. Like, buy a boat, buddy. Like, it's the most expensive hobby you could ever pick up. All right. The position that I held in Rwanda was funded in part by PEPFAR, funded in part by the U.S. government, and funded in part by the Rwanda government, and was administered by a multi-university consortium. That's how that job worked. I have had lots of jobs, and the funding model for each of those jobs has been a little bit different, and almost always the money has come from lots of different places, including sort of like the big name acronym verticals, the big name universities, and the countries themselves. There are other models other than that one, the piecing together, including what you mentioned, which is many people build this career based off of research funding. I'm not a great researcher. I hope one day to be an okay teacher, so I've had to build my career a different way.
Yeah.
Rasani talked about how you were told that there were shock patients that were just not savable in the setting that you were in. I don't know if any of you can speak to the question of where do you push to try harder to do something different to work a way out, versus when do you trust your colleagues for saying this is a salvageable case?
So in Lebanon, religion plays a big part, and so it actually was a struggle for me to have kind of actually like end of life discussions where this is futile, etc. And unfortunately, sometimes I had to push a little bit out of my comfort zone personally in terms of like I know this is kind of futile, but it gave the family a little bit of closure that you tried, and because also there's a safety aspect for me if I don't try anything, the family's going to beat me up as soon as I walk out of the hospital. And that's like a fact. And so I think we don't talk about, that enough in terms of global health and where you go there that, like violence out of emotion is also kind of a big thing that you have to account for. So I had to actually, sometimes kind of go a little bit, well, let's, go for another 20 minutes. And then you have to incorporate, religion into a lot of these discussions that, sometimes maybe I wouldn't do here or, have an easier kind of end of life discussion, especially in a very sick patient.
The parents are always watching, so I think that's even a harder thing. I think not that any older person's life is any more or less important than a kid, or vice versa. But it's just tough. These are things that I deal with even in my emergency room on when to stop. And I think the effort is important for a family, not so much for closure, but just to see that at least someone is helping their child as much as they can. So very frequent, the cases that we've had, we've done everything we can, and then at times we bring the families in, and it's not great, but I don't have a great answer for that question on where that line is, and I think we all struggle with that here. If anyone has an answer, I think they're mine, because I'm not sure personally where that would be.
I would also add to those very important comments that knowing your local epidemiology is critically important, right? So if I have somebody who has ingested a pesticide like aluminum phosphide that I know has a greater than 90% mortality, am I going to flog my residents and the patient through resuscitation that I know will have an outcome that is inevitable? I might choose to use that case for a time for everybody in my department to learn what really high quality critical palliation looks like, because the outcome's going to be the same. But if I can identify a case where I know that like this might be the one where I move the needle, or it might not, I have diagnostic uncertainty, I might say, guys, this is the one where we're gonna use our limited stuff, we're gonna use our limited energy on this one, because I think, based on this, and we'll talk about it later, I think this is the one where we may be able to make a difference happen. So it's picking your cases and knowing your epidemiology is a huge part of it.
Yeah, I would just, and I think that everybody's had really great points with this. I think the one other thing that I would tag on to everything that you guys are saying is nothing will alienate your local collaborators and colleagues more than you showing up with like the great American savior mentality where they say, oh, this is a futile case, we shouldn't be pouring a lot of resources into this patient, and you saying, no, we should use all of the resources in this emergency department for this one patient, and I know better than you do because I trained at such and such a university, and so I'm a really good resuscitationist. So I think going in with a lot of humility and asking a lot of questions is really important. But I think asking those questions of, oh, why is this futile? What resources are not available? Or what are the challenges in resuscitating this patient? And then how could we do things differently? And so like Bashar said, okay, this is somebody who you feel like needs to be intubated and we don't have the resources to safely intubate this patient and then care for them once they're in a ventilator. Well, it's not always a dichotomy of either intubate or do nothing. What other options do we have in there? And are there ways that we can troubleshoot this or innovate here to figure out ways to do some resuscitation within our local resource constraints? But I think it needs to be, you need to start with asking questions and having a dialogue and not showing up thinking that you know everything. I want to thank everybody for your being here, your engagement, your interest in this. Feel free to contact any and all of us with more questions. This is something that we're all really passionate about and would love to talk about more. And then definitely, if you're interested, shoot me an email about the IFM Critical Care SIG, and hope to see at least some of you online at ISEM next month. Thanks, Lord.